So, hello together. So, welcome on behalf of the European Academy of Optometry and Optics. I think it's 6 o'clock now. Yeah, and it's time for academic hour. Even it's at least in Germany pretty hot outside, but I'm here in a cool office, so that's fine. Yeah, and it's a pleasure to have you here, and even a more pleasure to have a really good and interesting continuing education. We have here Brughanya. She's a PhD student at the University in Tübingen, and I think everybody knows that this university is one of the well-known and it really has a good reputation, not only in Germany but worldwide in the field of ophthalmology. And yeah, so our speaker today, she is an optometrist and she's from India originally and worked there as a clinician, but did also like over 5 years of researcher as well. And now she is continuing her research on a PhD level. And she want to share her experience, yeah, about her clinical experience. So that's great. Just I want to mention that we also have an accreditation for the CPD points. For colleagues who are from UK. So if you need or wanna these points, please send us the GUC number. Yes, if you have any questions, you can make the questions on the chat. Or after presentation, you can also talk and unmute yourself. So, but we are going to answer the questions afterwards. So now it's enough from my side. And yeah, I think stage is yours, Brughanya. Thank you that you are here today.
Thank you, Georg, for the lovely introduction. I feel honored to be here and present at the Academy Hour. And I would like to thank EAO for providing me this opportunity. So, yeah, sure. I'll share my screen now. Okay. Is my screen visible?
Yes.
Okay. So today I'll be talking about the topic of clinical decision making in everyday practices and how can we proceed with referring, monitoring, and to make any kind of decision with that particular patient. So the question might sound very simple, but the reality is it is a really important management skill that we as an optometrist and primary eye care providers face in our everyday situations, right? So in this session, we'll see about how to manage all these legally important cases in a safe and a structured manner. So I would like to proceed now. So why is this topic the need of the hour? So as we all know that the posterior segment diseases does not only involve diagnosing the patients, it involves the management as well. And the management is actually associated with a lot of consequences as well, because the patient is the one who is going to be the one who is going to suffer or get benefit at the end. So it is crucial for optometrists as us to make sure that the patient is getting benefited from whatever decisions that we are taking to. So the entire clinical decision is basically divided into three major branches, and I've grouped them together here. So the first one would be over reference. So the name, as the name suggests, it includes continuously referring all the cases that we encounter here in the clinic, but that is not the case here, right? So we are not supposed to refer all the things that we are seeing in the clinic. So it is a duty of an optometrist to make sure that the right patient is referred at the right time so that the patient will be benefited from it. So the over referral also creates anxiety in patients, and because he's also like worried about what is going to happen, like if I'm getting referred continuously, right? And it will also like going to create a huge burden for the ophthalmologist as well. His or her clinic is going to be very crowded, and it is going to get very chaotic in managing all of those things. And the next one would be under referral. So here the optometrist is actually ignoring the risk of the entire case, and then he's not going to like refer them at the right time. And here the patient is the one who is going to suffer. So the role of an optometrist plays a huge pathway in deciding what is actually going to happen if the patient is not referred at the right time, right? And the last one will be delayed referral. So the idea and the decision to refer has already been taken, but it is taken at the wrong time here. So the early intervention, which is going to like have a huge impact on the patient's vision progression, is actually getting impacted here. So to avoid all of these chaotic experiences, the role of an optometrist here plays a huge thing in order to make sure that the patient is the one who is getting the benefits as well as the optometrist as well. So the goal is to make a safe, proportionate, and timely decision making here. So these are the learning objectives that we'll have at the end of this session. So first is to apply a structured framework to the posterior segment findings in the primary eye care. So I'll talk about this in the upcoming slides. And the second is to differentiate urgent referral, routine referral, and monitoring and reassurance. And the final one is to recognize the optometrist's role in documentation and referral quality as well. So first we'll look into how to create a structural framework for referring all of these patients. So as I said before, not all of these patients deserve to be referred, right? So there are like situations where only certain patients can be referred and only certain patients like cannot be referred. So those patients need to be reassured. So I'll first initially talk about the structured framework that I used to use in my clinic when I practiced as an optometrist. So I would like to share that here so that it will give a pathway for you to have a idea about what to refer and where to refer and like how to refer. So this is the real question. So the real question is not about like what is the entire condition is all about, but the real question is all about like what are we going to do when we are seeing a clinical case like this. For example, like certain cases like requires, for example, a patient might present with same symptoms or even share the same retinal signs, but not everyone is going to be referred, right? So this is a case example that I have. So this is a fundus image which shows floater present here. So both these patient A and patient B arrives with the clinic with the same symptom of floaters. Okay. So patient A is 25 years old male. He is an eye myope and he has like new complaints of flashes and a shower of floaters just one day before. And his fundus also shows horseshoe tear. But the patient B here is actually 55 years old male, but he's not a myope, but he also has a like a complaint of seeing a stable like floater for about 5 years, but he's not experiencing any flashes. But the catch is he is diabetic for 10 years, but his fundus is appearing normal. So both of these patients comes to your clinic with the complaint of seeing floaters, but you are only referring patient A because the patient A is actually under urgent referral due to the fundus similarities. So he shows horseshoe tear and a risk for retinal detachment. But patient B, even though he has a history of systemic diseases, he is not under the risk of losing his vision right now at the moment. So he can be monitored. So the decision here is to reassure the patient that you have a certain condition in your eye which can develop in a few years as something as simple as lattice hole or something like vitreous, for example, like vitromacular traction, whatever it is. So you here the idea is to make sure that the patient B is reassured properly with good communication, but patient A need to be referred urgently as soon as possible because he shows the symptoms and like fundus image outputs, like for example like retinal detachment, right? So it is crucial as for an optometrist to make the decisions in the right time at the right moment. So here the patient A is going to be referred urgently and patient B is be reassured. Even though they share the same symptoms, they are not even like they have different decisions that needs to be taken from an optometrist side. So this shows the entire dilemma that how a management is more important than that of like identifying or like diagnosing a patient. So diagnosis only not enough here. So the critical clinical management plays a very important role in protecting the vision of all our patients. So but by keeping that in mind, now we'll move on to the next slide. So this is the one entire framework that I've been using all these year to accurately refer all of my patients who are like coming in various critical categories. So, for example, I would like to name this as STAR. So it is easy to remember, and this is something that is actually quick for us to like see what is there inside the patient's, like see if the patient is having all of these categories. So the S here stands for symptoms. So it is very simple, like we'll first have a note whether the patient have any like sighted threatening symptoms like sudden flashes, sudden floaters, or sudden loss of vision. So and then the T stands for threat to vision. So as the name suggests, like if the you'll have to like look into the entire fundus photo and see if the lesion is located near the macula, or if you are gonna like see if there is any like cases, or like for example, like if I am going to refer this patient immediately, will that save this vision of the patient? So that is the important thing to notice here. And the A here represents appearance. So this actually says how big is your lesion and how severe is that case. Particularly, for example, in the previous thing we case we saw there is
Have
a
a lovely day off. Right.
in the previous case we saw that there was a sudden appearance of floaters, right? So the appearance, and you also had a horseshoe tear. So that is one of a sight threatening factor that we need to take into account. And the R here stay for risk factors. So does the patient have any diabetes or hypertension, or is there any family history which is going to affect the vision of this patient? So before making any clinical management, I would like all to like remind all of you to have this star in your mind, so that it will be easier for you to like ask this question to yourself before proceeding to any kind of like management that is there. Okay, so what is a contribution from an optometrist side? So we all know that optometrist is a primary eye care provider. So the patient is going to come to us initially before going to an ophthalmologist. So the role of an optometrist is to properly detect what is there in the findings, and then documentation, because documentation plays a like important role in tracking the progression of all the diseases. So a proper documentation of all the visits of the particular patient is really important. Both the baseline and the recent visit has to be tracked properly in order to make the management a smoother way. And then the risk assessment. So here the star factor comes into play. So the star factor you need to apply it here, and then see if there is any risk or threat to vision. And then proper communication with the patient. Even though if you're like referring the patient to an ophthalmologist, it is a duty of an optometrist to make sure that the patient is very well prepared about what is going to happen if they are like going to visit an ophthalmologist clinic, right? You shouldn't be blind and just be referred that it cannot be seen here, you need to move to an hospital for a treatment, right? So he need to be made sure and well educated about what is the condition he's actually going through, and what are all the consequences that he will face if there is any delay or like loss to follow-ups. So you need to make sure that the patient is educated properly before referring here. And then the referral process comes here. So the referral process, as we have discussed earlier, there shouldn't be any chaos in the referring. So urgent referral or delayed referral or under referral shouldn't be here. So the proper clinical management need to be here for an ophthalmologist. And then monitoring. So in cases if you are not referring that patient, you are just reassuring that patient, a proper a patient education and monitoring. So monitoring here involves like a structured follow-up. So you need to document all the visits of the particular patient, and then make sure that the patient is monitored very well in all of these visits. So yeah. So now let's look into this urgent referral. So this is something that we saw in the previous case history, right? That male who was only 25 years old, who came with a complaint of sudden visual flashes and floaters. That is like a typical case of an urgent referral because he had the risk of retinal detachment. So urgent referrals need to be done only when the symptoms are acute or sudden, and then there is a threat to the vision or central vision, and there is the sight threatening pathology, for example a horseshoe tear or like wet AMD or something like that, and the suspicion of neurological and systemic emergency. So this I'll like talk about in upcoming slides. So here the role of an optometrist is to recognize that there is a threat to the vision, and then you need to document all of your findings here, and then proper communication with the patient is a must. You shouldn't like bombard the patient with facts. We need to make sure that it is not the duty of an optometrist to threaten the patient here, but rather to empathize with them and say that, hey, there's something that is happening in your eye which could like actually affect your vision, or you could lose your vision if you're not going to treat it immediately. So make sure that you visit your ophthalmologist immediately. So it's just that giving the facts in a crisp manner, not sure like not you shouldn't be like threatening them, and then you need to like empathize with them appropriately so that he is be like made well aware that okay, there is something that is happening and I need to like see my ophthalmologist right now, and then you need to refer them. Yeah. So I have even a case example of one of those patients that I saw when I was practicing here for an example of urgent referral. So this is a case of a papilledema patient who is a 50 years female. So she came to my clinic with a prolonged headache for 1 week and a sudden vision loss. And she also been like had a history of hypertension attacks, and she has this immense stress at job. So when I examined her, I could see the vision in the left eye was only CF at counting fingers at 50 centimeter, and right eye vision was like okay, and IOP was also like fine. And when the diagnosis was made, she was like having papilledema. So these are all the images that I have from her. So the visit one showed a fundus like this with edematous disc and tortuous veins, and these are all the OCT findings that I found. Like shows that there is a huge edema here, and when I referred this patient right away, the patient benefited also, and then the doctor was able to like manage the patient at the right time so that her vision was preserved. So the visit two, like when she followed back after 3 months, her headache problem was resolved, and there was a slight improvement in her vision. So the visual acuity like was about 6 by 48 in the third visit, and she was also under medications for this. And during that visit, she was diagnosed with hypertensive retinopathy grade 4. So these are all the images of her visit 2. So you could see the difference here in the disc as well. So the visit 1 had a huge edema, but visit 2 was like completely fine, doing good here. So these are all the OCT scans of her visit 2. So this is a classic example where you need to apply your START framework. So here, when you look at the symptoms, yes, she had huge symptoms. And is she having any threat to vision? Yes, she had. And the appearance, so it looks severe. It disc look edematous in the first look. So it is a very severe case. And risk factor, yes, she was actually having this hypertensive attacks also when she came to me. So this is a classic example where you need to refer this patient urgently. So if you are really confused about how to like what to do when you encounter with such situations, you can apply this star category and ask the questions to yourself and see if all of these categories are like yes, 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 and then you need to be sure that okay, I need to refer this patient urgently. Okay. And this is another example of another patient, which was under urgent referral. So here, this is a case about a 42-year female. So she came with a acute vision loss in the right eye for 1 week, and she did not have any like systemic disease as well. So our visual acuity was counting fingers at 1 meter, and IOP was also like within the normal range. But in when I referred this patient to the ophthalmology clinic, they also did a systemic evaluation as well, and that like came to be diagnosed as this patient had leukemia. So here the crucial referral is not only for an eye, but it could like bring up something that is really there in their entire body as well. So the systemic diseases paves the ocular diseases paves way for systemic diseases as well. So it is always a well-known fact that eye is a window of all of your like health, entire health, right? So this patient was referred at the right time, and it turns out that the patient had leukemia as well. So these are the fundus images in our first visit, but unfortunately I couldn't have the follow-up visit of this patient. She didn't come back to my clinic, so I couldn't track back the data. But this is the first visit that she came with. So she had retinal vein occlusion, and there was like a lot of tortuous veins here, and I could see rot spots also here. It's marked here, and FFA also like reveal like delayed filling in the hemorrhagic places as well. So when you apply star framework here, it shows a similar pattern as that of the previous papilledema case. So this is a clear sign that this patient needs to be referred urgently. So yeah, the symptoms were present. There was a threat to vision, and then the appearance was really severe. And the risk factor also, yes, because even though she did not have any systemic disease as well when she came or reported, but the fundus is looking very scary, right? So it is showing that there is some sort of threat to the vision. So this patient need to be like referred urgently. So always a decision making need to be involved a series of framework. It shouldn't involve only the symptoms or only the systemic disease. It is a cumulative decision that need to be like having all of the symptoms or appearance or risk factors. Everything should come together in order to make a proper clinical management. And then there is routine referral. So this is a category that is present after the urgent referral. So it is used to be like done in cases where the patient have dry AMD or moderate DR. So there is a risk for vision here, but it is not as urgent or vision like sight threatening as like urgent referral. So here these are all the images. Like there is a picture of dry AMD here, and this is a case of moderate DR, and then there is high myopia here, and then there is ERM. So when you apply star here, so is the patient symptomatic? No, they just came here for a regular eye checkup. But is there a threat to vision? I would say yes. Not only if it is going to progress, then there is a higher chances of happening that the patient is actually going to lose their vision. So there is a threat to vision here. And the appearance, so it appears to be at the early stage, not at the like critical stage, but it is an early stage. And the risk factor, yes, the sign is already been present. So you need to make sure that there is a proper communication to the patient so that they can follow up frequently, not just like just come report, get your eyes checked, and then you need to like vanish off. That shouldn't happen. So here we as an optometrist should make sure that the patient is being very well educated about like the risk factors that could happen if they lose their follow-ups. So yeah, so this is the role of an optometrist. So first one is to document everything. So this is your first visit, you need to document everything, and then you need to educate the patient, you need to have a proper communication with them, and then you need to refer them appropriately and make sure that the patient is following up. Only when you like emphasize on the follow up, they will be able to like do it appropriately. Otherwise, if you're not emphasizing on the visual threat that is going to happen, then they'll like be like very careless about that, and then they'll not even follow up. So the next one would be monitoring. So we saw urgent referral and routine referral. Now we'll see what is monitoring. So here there are no major symptoms that is going to hamper the vision, and there is very limited threat to the vision and no immediate threat. And the risk is also very minimal, and the findings need to be documented as well. So here, many people actually like think that the role of an optometrist here, like role of monitoring, is actually not really that good. But documentation plays a crucial role in monitoring. So, how will you know that the patient is under risk without knowing what is happening in their eyes previously, right? So, I'll show you a case example. This is a case of a 50-year-old male who came for a regular eye checkup, but he is diabetic for 8 years, and vision was actually like within normal range, and IOP was also normal. But the fundus exam shows mild DR changes. There were like only one microaneurysm here, and then the OCT findings were also like normal. So uh, I would be like wondering like what will happen like when you see or spot a DR changes. You shouldn't be like, oh my god, I could see a finding, I need to refer them immediately. Rather, you can apply the star here. So for example, you can say, is the patient symptomatic? No. So is there any threat to vision? No. But the appearance, it looks like an early stage, and the risk factor, yes, if the patient is not going to take up their diabetic mellitus as a serious concern health issue here, he might end up having a DR, right? Like diabetic retinopathy in few years. He is already being a diabetic
By the
mellitus
big
for
record,
8 years,
when you record.
but the patient is under risk if he is actually not going to get his control over his diabetes mellitus. So it is, I wouldn't refer this patient
Over
immediately.
at the
I would
fucking
make
there,
sure
you
that the patient is like very well, like advised about the conditions and the health risk he is going to face if he's not going to place his like or like not going to watch his diabetes mellitus levels, right? So first I would suggest him to have his diabetes range under check. So and then I would ask him to come for a follow-up. For example, like he can have a regular and yearly follow-up so that he is under check, and I would document all the findings. So this is the first follow-up that he came here, and then I would ask him to come back frequently every year or every 6 months based on your convenience, and then you can decide whether if that thing is actually spreading out throughout the fundus or is he losing his vision, anything like that, and then make sure that he is being referred appropriately if it has is actually progressing. Otherwise, there is no need for referral in this case. So the last one would be like reassurance. Here, the there is no like critical conditions that is going to happen the patient, and the lesions are all like very stable and very benign. So the ideal role of an optometrist here would be is a good proper communication and to make sure that you're under check. So these are all few conditions like myelinated nerve fiber layers and fresh lattice you are going to notice in early myopes. For example, like if someone is like 17 years with a myop for about 10 years and you see a lattice like that, you need to make sure that the patient is coming here for follow-up frequently, right? So you shouldn't threaten that, oh my god, I could see a lattice. You might have a chances of losing your vision if that is going to develop a hole inside your eye. So you need to rather, I would ask the patient to come for a frequent follow-up every 6 months, and I would make sure that the lattice is actually stable, right? So you shouldn't refer these cases here. So rather, you need to like make sure that the patient is being well educated about the case. So uh, and then there is vitromacular traction here. So here in the right eye, there is diabetic macular edema here in this patient of, and in the left eye of that same patient, you can see like vitromacular traction here, but it's not really a traction, but it might develop as a traction in any time soon. So here, this plays a crucial role. The right eye needs to be referred like urgently because there is a risk of losing the sight here, but the left eye need to make sure that like the patient is being educated properly about you. Hey, look, you have a like a condition going on in your eye, and then you need to make sure that you come for follow-ups regularly so that your vision is not getting affected at all. So when you apply star here, you'll see that symptoms are like completely nil, and that there is no threat to vision. For this left eye, the vision is like actually normal, and the appearance, so it looks like an early stage, and the risk factor, if it is actually progressing, then yes, otherwise it is nil. So here the communication plays a crucial role so that there is the patient is actually getting benefited from the same. So these are all the common pitfalls that as an optometrist faces, because you're like by ignoring symptoms and monitoring without documentation. And always, like, I would like to emphasize the fact that good visual acuity is actually not a sign of low risk, because a patient might have a really good vision, but he might have a peripheral lattice hole which he is not even aware of. And except for the floaters, you wouldn't see any hindrances that is happening, right? So that is not a proper sign. And then there is no previous comparison, so this involves proper documentation and all the visits. So these are all the key take home messages. So diagnosis alone should not determine the management, so that's the crux of my talk. So you need to like be make sure that the star is being applied in all the patients that we encounter on daily basis, and documentation is essential. And of course, like, monitoring is an active management. So yeah, of course, like, when you monitor a patient thoroughly for all the follow-ups, and the patient is actually like coming to your clinic regularly, then there is no risk that this could be missed. And then there is a structured framework. This is the star that I just talked about. So with that, I would like to end my talk here. So I'm happy to take any questions if there are any. So yeah, thank you so much for offering me this academy hour. Thank you.
Hey, thank you so much. Really interesting talk. Great. So, actually, I think we do not have any questions in the chat. So maybe somebody else wanna or have a question who wanna say or ask live here. Yes, no, maybe. You can just unmute yourself and are free to talk. Otherwise, I will do, Mike, because always have questions. So just if we go back to case one, it was this kind of papillar edema on one eye, isn't it? It was only
Yeah.
one eye affected with papillar edema. So it's so the
No, no,
swollen optic nerve head, it was only on one eye.
no,
And
no. That is a case of both eyes being affected, but I showed only the right eye
okay,
image. Yeah.
okay. But if I remember correctly, so it was the VA was okay on one eye, but pretty worse on the other eye, isn't it?
Yeah. Yeah.
Yeah. So, but both I was affected, and then you said, but the cause of this edema was hypertension, isn't it?
Yeah.
Okay, but it was on both sides. So that was
Yeah.
I thought it's only because the VA was that kind of differently. I thought because if I see it on one eye, we always think on the AION, and so okay, great, perfect. And then you talked about a little bit about the peripheral retina. The thing is, this the scope of practice in Europe are differently from country to country. It's in some countries, optometrists are allowed to dilate the pupil, and other not. So in some countries, we have not that really good knowledge about the peripheral retina, and you
Oh.
mentioned about something retinal holes and the lattice thing, and you said lattice is not really an it's more a benign finding, isn't it? You can say something about the lattice degeneration.
Because I gave here the examples that is being practiced in India, because I'm not
Yeah.
really sure about the thing that is here in Europe, because these are all the cases
Mhm.
that I saw as an optometrist back in India. Because there in India, we consider lattice as a not as a visual sight threatening thing, but we would always like advise the patients to have this frequent follow-ups, because if the lattice is present without the hole, usually that is a condition that you see in high myopes, right? So high myopes tend to have like a proper follow-up than compared to other persons. So the follow-up is actually pretty good in India. So yeah, so there is no risk of losing that patient in any time soon. So every 6 months there used to be a follow-up very frequently. So yeah, every 6 months we used to see that same patient. If something is actually alarming in that point, we would like consider as a treatment there.
Perfect. So great. Yeah, so the lattice is just more or less a thinning, isn't it? And we are
Yeah,
relaxed, but we have to monitor it. Yeah,
yeah.
that's that's correct. Okay, thank you so much. So, have you more questions?
Hello, hi. Thank you very much for your
Hey,
talk. It's a pleasure to have you here. I have a very quick question. In the end, you have a headline of treatment should not depend only on diagnostic, which is completely correct, of course. Uh, in the recent times, with the guidelines, consensus guidelines, and everything that we are seeking to guide us towards proper management of patients, maybe at sometimes we try to make the thing so algorithmic that we try to follow decision tree very strict. So could you elaborate a little bit more on that statement? Because I fully agree, and we have to follow the guidelines, but at the same time be flexible. Could you elaborate a little bit on that?
Yeah, sure. Thank you so much for asking the question. So, I think that we, as an optometrist or any primary eye care professionals, have been taught just to identify what the case is all about. But the idea is it is not the entire thing, right? So, it is about what we should do next. So, that is how we'll be able to like manage the patients, right? So, it's not if you are identifying a patient with say high myope and you don't know like what to do next. So, what am I going to do now? So that shouldn't be the case, right? So the next step would be to like ask him to come for a frequent follow up and then say that, hey, I could see so like you have like a higher number in your eye and you need to like explain those things. So make sure that the patient is actually like that is what I like said about the proper management. Make sure that the patient is like informed about what is happening in his eyes, and then like make if in case if he develops a condition like lattice or a hole or a retinal detachment, need to make sure that rather than just identifying like, hey, I could see a retinal detachment, you need to make sure that yeah, now I need to refer this patient immediately. So that is the entire circle of management that I wanted to like emphasize in this talk. So yeah, so have I answered your question? Yeah, thank you.
Thank you, Jose. Then we have another question from David.
David
Can you?
Parkins, yeah.
Yes, exactly. Maybe you can unmute yourself, or maybe Daniela or Christina can do it. Perfect. Almost.
Hi, thank you very much for your talk. George makes a good point that across Europe, the referral decision making is quite different depending on their referral pathways, their contract, their scope of practice, etc. You made the point particularly around monitoring. So in the UK, we would not be able to do that under the NHS because we only can do a monitoring aspect or a sight test every 2 years, for example. They get a free sight test. And if you monitor, say, too much, you would probably have an inspection or two around that. So you tend to refer because you cannot manage it within the system. You made a point, particularly in diabetic retinopathy, early changes. The reason why that would happen would be uncontrolled diabetes. So it's really important that you advise their clinician who's managing that, because that's the reason why it's going to deteriorate. Your follow-up doesn't really matter if they're not controlled. So you know, the first point of intervention surely must be with their general practitioner in order to ensure that they are fully controlled and they're behaving as they should within their controls or diet.
So I think I left that point there. So I was about to say that this patient shouldn't be referred to an ophthalmologist, but rather that they need to make sure that the diabetic level is under check. So I think I just missed that point. So thank you for actually reminding that. Yeah, that's the point.
And another point, I think we tend to treat all optometrists as the same. And the research I found was particularly people who are newly qualified are much more risk averse to taking decisions of monitoring the patient or not referring on possibly lower scale pathology or symptoms. And so they tend to be more risk averse in everything they do, because there is nobody to talk to sometimes or to do that. So I think talking to somebody within the practice is really important for newly qualified to get that kind of feedback. And of course, the other thing that is not always there is the feedback from ophthalmology on referrals to determine whether that was a good referral or not, or a poor referral, and any kind of feedback in order to manage that patient thereafter. So communication is two ways. It's not just one way, and it's really crucial to learning.
Yeah.
So good presentation, but there's a lot more that can be said on this subject.
Yeah, I agree. Yeah, thank you.
Thank you so much. And that's an important point. So we not only refer to ophthalmologists, but as well to other professions, of course. And what I do meanwhile in my practice, if I want to refer patients to physician, I always sign for I'm allowed to talk to the physician, and he's allowed to talk back. So I do this. How do we say in English? This confidentially thing, yes. And then I send it with my referral to the a physician, and then he see, okay, the patient already agree that he is allowed to talk to me, because in the past I never got feedback, and I was wondering why they don't talk to me, but they don't allow to talk to me otherwise. So yeah, so that's a good point.
Yeah.
Okay. So do we have more questions? I think nothing in the chat. So then, thank you so much. It was really great, interesting. Thanks for your insights and to share your knowledge. And maybe we hear you again, maybe about your PhD. So that would be also interesting too, what I heard so far. So thank you so much. Have a nice evening. And yeah, thank to everybody. So please check the homepage regularly for more academic hours and events, and also the members of European Academy to join the SIG events, the special interest groups. For these attendees who are not member at the European Academy, please join, because it's a really cool community. It's really worth it. It's not that expensive. And yeah, I really learned a lot here at the European Academy. So thank you so much. Have a nice evening and see you soon. Bye-bye.
Thank you. Thank you. Bye-bye.
Bye. I think somebody else have to end the session, because I